Okay. A very good evening to everyone. I am Dr. Sanjog Mekewar. I am Secretary of Society of Study of Pain, Pune. And today we are here for our monthly webinar series that we do frequently as a part of our academic program of Society of Study of Pain. Uh, Now, what is new about these webinars that we are going to do from here on? So, our academic team was working on what new things to do research on, what new things to study on. So, we came to the concept of fascia, which is a very, you can say that it is not a new concept. It is an old concept. A lot of studies have already been done on this concept. People are treating fascia related things, but there are new frontiers which are coming into the things which are related to fascia. There are a lot of new, you can say, discoveries, a lot of new techniques that are coming into being, which are dealing with the chronic pains which are associated with fascia. So we thought, why not take this as our theme, because it is such a vast topic, and there are so many, you can say, disciplines of medicine which are working on the treatment of this fascia. It is such a large network which is present all throughout the body, a continuous, you can say, a layer which is present on all the muscles, nerves, and organs of your body. So it is such a big network of tissue. It is so much rich in sensors. It is packed with nociceptors, mechanoceptors. So it is a very important source of pain, or it is a very important pain generator, which is often overlooked by many physicians. Now it is many a times linked to the chronic low back pain. So you can see many cases where your MRIs are normal, your X-rays are normal, and patients are still complaining of these chronic pains. So these are the patients where you can explore the option of fascia,
Very
which may be
important
causing
pain
pain in your
generator, which
patients.
is often
And
overlooked.
why it matters? Because it causes severe dysfunctions. So it is not about some normal pains here and there in your neck and back. It is about severe dysfunctions because of the stiffness, adhesions, and inflammations. And many a times it starts from one part of your body and then spreads all over. I've seen many cases of neck fascia pains, myofascial syndromes, who have undergone angiographies just because they were complaining of chest pains, which was secondary to
Because of
these
the
kind of
stiffness,
myofascial
adhesions, and
syndrome.
inflammations.
So a lot
And
of
many a times it
you can
starts
say
from one part of your
troubles patients have to undergo because of these kind of pains. And a lot of new targets for diagnostics and intervention procedures. We are hearing about the perineural hydrodissections, interfacial plane blocks, or plane hydrodissections. So these are the new things which are coming into being. So considering this, we thought about doing a conference, a full 2-day conference in the month of April in 2026. And the theme of this conference. So we are starting this conference as the first annual conference of Society for Study of Pain. And the theme for this conference we have kept is unraveling fascia, the hidden key in the chronic pain. And before we go for this national conference, we will be doing monthly webinars, which will focus on the different aspects of fascia, the pathologies related to fascia, and various treatment options. So don't miss these webinars, because they will be very, you can say, informative, educational, and it will definitely help you in your clinical practice. So, starting this webinar series, we are starting with a first topic, which is fascia as sensory organ. And for this, I will invite Dr. Priya Rathi, who is director of Sigma Spine and Pain Clinic and visiting consultant in Sancheti and Manipal Hospital, Pune, and a very dynamic young pain physician of Pune, who deals with all these kind of myofascial syndromes in her day-to-day practice. So I would request Dr. Priya Rathi, please start your presentation for today. And over to you.
Thank you so much, Sanjog, for the kind introduction. So,
You can
let me
share
just
your presentation. Yeah. Yes, we can see.
as a sorry, as a pain physicians, we have always been talking about nerves as pain generators, joints as pain generators, or discs as pain generators. Recently, we had started about muscles as pain generators, but about fascia, we have been forgetting this 22 kg organ, which is completely interlinked from head to toe in our body. So, even during our anatomy days, what we used to do is we would just cut the skin, separate the fascia, and go to the organ directly. So, we would be so keen on seeing the brain, we would be so keen on seeing the muscles, we would be so keen on seeing the stomach. But I'm very sure that none of us had ever focused on fascia as an important organ. So now, about musculoskeletal system, we know the skeletal system, we know the muscular system. Just a minute. I think I lost my screen. I don't know why. I'm able to see only the speakers.
We can see your slides, Priya.
Yeah, but on my screen, yeah, now I'm okay.
Okay.
Again, the same issue has happened. I don't know why.
You can mail me and I can share it from my side if it is causing
No,
any issue.
now I'm okay, I believe. Yeah. So we know muscular system, we know the skeletal system, but there is third system which keeps all this system binded. That is the syndrome of body system. So this term was coined by Dr. Robert Schlepp, and it is the fascial system, which we call as simply as packing material. So fascia literally means band in Latin, and it's a band or sheet of connective tissue, primarily the collagen tissue, beneath the skin, and it attaches, stabilizes, encloses, and separates muscles and other internal organs. And it is not seen on any investigations. So why fascia is being neglected? Initially, the anatomists wanted to understand the organs. And Myers in 1987 said that the traditional approach that studies the muscle as independent unit has been the barrier to understand the bigger picture of facial functions. So what we usually do in anatomy dissection is we try to learn individual muscle, and that's why we cut fascia all over that muscle and study the muscle. So but recently there has been great interest in both basic as well as applied research in fascia, and it is evidenced by increasing number of papers which are being published in PubMed, and greater participation into the congress which focus on the fascia. So uh, we can consider fascia as the broth which connects, which penetrates, permeates, and separates the muscles, bones, ligaments, tendons, fat, and skin, and everything else. So, fascia, it begins as one entity in second week of birth. In second week of gestation, and it remains as single connected web from birth to death. So we know that there are 600 muscles in the body, but if we dissect the fascia properly and we see it as a single organ, it's accurate to say that one muscle is poured into 600 pockets of facial web rather than saying that we have 600 muscles in the body. So this illusion of separate muscle is being created by anatomist scalpel. Why I'm saying this is because there have been certain anatomical dissections where they have demonstrated that you can see here biceps femoris long and short head. The fascia covering that muscle is continuous with the fascia which covers the peroneus longus, which in turn is continuous with the tibialis anterior, and which in turn is continuous with iliotibial tract and tensor fascia lata, which we didn't know till now. This is another example. Here, the plantar fascia is continuous with the tendo Achilles, which in turn is continuous with the fascia covering gastrosoleus, then hamstrings, then sacrotuberous ligaments, erector spinae, and scalp fascia. Can you see the single uh, dissected model? So the connections are from head to toe. Here is another example where quadriceps tendon getting attached into patella but sending retinacula around the patella and having connections with the anterior compartment of leg with tibialis anterior and extensors. This is another model where splenius capitis is continuous with the rhomboid serratus complex, which in turn is continuous with the external and internal oblique and peritoneal fascia. So you can imagine how pain can travel from one part to another part if there is dysfunction in one part of the body. So this is how they have started preserving fascia in anatomic models. This is a plastinated model of the thigh where you can see femur and there are the fascial compartments. This is the anterior compartment, this is the posterior compartment and medial compartment being separated by the fascia attached to the linea aspera. So plastination is the technique where we can preserve the organic matter indefinitely by replacing water and lipids with the plastic. So, but there have been paradigm shift in understanding of the fascia. Fascia has important role in venous return, dissipation of tensional stress, which is concentrated at the site of enthesis. Etiology, it can be the etiology of pain. There are interactions among limb muscles and movement perception and coordination because of the fascia. So it's not just the packing material. It has multiple different roles in our body. So muscle tension transmission happens 70% through the tendons and 30% happens through the fascia. And it acts as body-wide proprioceptive communicating organ. So this is how the skin structure looks. The structure looks like. Here is skin, then there is layer of fat tissue, then superficial fascia, then deep fascia, epimysium, and muscles. So in detail, if you see, each muscle fiber is being covered by endomysium, then muscle fascicle is being covered by the perimysium, and the whole muscle is being covered by epimysium. So deep fascia, it's the dense fibrous tissue that interpenetrates and surrounds the muscles, bones, nerves, and blood vessels of the body, binding all these structures together into the firm compact mass. So it includes periosteum also if it goes around the bone. Can it can be paratendon if it goes around the tendon. It can be neurovascular sheath to cover the neurovascular bundle. And around the joint, what it will do is it will strengthen the capsule and ligaments. So there are two types of fascia. One is aponeurotic and other one is epimysial. So aponeurotic fascia, as the name suggests, it's a well-defined fibrous sheet that covers and keeps the group of muscles into a place, or it serves as the insertion of broad muscles like thoracolumbar fascia, which gives attachment to the latissimus dorsi, or fascia lata, or crural fascia. So these are all aponeurotic fascias. So this aponeurotic fascia is formed by 2 to 3 layers of collagen fibers, which are angled to each layer is angled at 70 to 80 degrees. So it helps in transmission of the forces. So this each layer is separated by loose connective tissue which permits the gliding of the layers above the adjacent one. And this gliding is very, very important for the smooth uh, movement of the muscles. This fascia is richly innervated, predominantly in the most superficial sublayers. As we have seen that there are 2 to 3 layers, but most superficial one layer is being richly innervated. So myofascial insertion of this aponeurotic fascia it shows constant presence of some expansions originating from pec minor, latissimus dorsi, and deltoid muscle. All of these muscles, all of these myofascial expansions, they merge into brachial fascia. Another example is the lacertus fibrosus. Lacertus fibrosus is myofascial expansion of the biceps brachii tendon, and it inserts into the forearm. So your median nerve travels just below the lacertus fibrosus. So carpal tunnel-like syndrome can happen because of entrapment of the nerve at lacertus fibrosus. Okay. Then another example is patellar tendon. So quadriceps inserts itself into the patella with patellar tendon, but it sends the fibers into the retinaculum around the knees. So it is connected with the anterior compartment of the leg also. Then another example is your, as we all know, is plantar fascia, which is continuation of the fascia of gastrosoleus and tendo Achilles. Now, epimysial fascia, they are the thin collagenous layers that are strictly connected to the muscles. So epimysium is the form of fascia. So it is able to transmit the forces between the adjacent muscular fibers, whether they belong to the same unit or it can be the different motor unit. And they have the same organization as of aponeurotic fascia. So under microscope, they would look the same, just that the location is different. So this space between the collagen fibers of epimysial fascia is occupied by the ground substance, which is rich in proteoglycans, and in particular, it is hyaluronic acid. So previously, it was loose connective tissue between the aponeurotic layers, aponeurotic fascia, and here it is mainly hyaluronic acid. So this epimysial fascia have free nerve endings, but there are no Pacini or Ruffini corpuscles. So it's more of a pain-carrying fascia, but it has no role in mechanoception, and it makes connection with another type of nervous receptor, that is muscle spindles. So it has role in uh, maintaining the muscle tone, because muscle spindles are associated with maintaining the muscle tone. Now, the most recent discovery about fascia is myofibroblast, which are the modification of the fibroblasts. So these myofibroblasts, they make the fascia contractile to certain extent. So till now, we knew that fascia is non-contractile, but no, the fascia is contractile to some extent. It is not stimulated. These myofibroblasts are not stimulated by any nerves, but they are stimulated by chemicals like antihistamines, oxytocin, and sustained mechanical tension in fascia. It takes minimum 20 minutes for the contraction of the myofibroblasts to build up, and it takes at least few hours to for the contraction to completely go away. So it's not like our muscles. But we don't know whether these myofibroblasts are pathological or not, uh, or and whether they are normal or not, because myofibroblasts are seen mainly in the open wound, because after injury these fibroblasts are being changed into myofibroblasts, so that the the wound is being healed, and certain tension is being developed at the end of at the edges of the wound, and unhealthy fascia has many myofibroblasts. So whether myofibroblasts are pathological or not, because in superficial fascia, they are probably always present. So there is confusion whether they are normal or they are always pathological, that we don't know. Again, the most fascinating discovery in fascia is the new cell, that is fasciacyte. It is being discovered by Dr. Carla Stecco. She is an orthopedician and anatomist, and she has more interest into fascia. So she has lot many research papers in fascia. So she has found this cell uh, called fasciacyte. This fasciacyte, they produce hyaluron-rich extracellular matrix, and these have same feature, some features similar to fibroblast, and it is essential for the facial gliding. And regulation of these cells could affect the function of fascia, so that that could be implemented in myofascial pain. Now, nerve supply of fascia. So, fascia has free nerve ending. It has the capsulated nerve fibers. So it has both sensory as well as autonomic innervation. So encapsulated receptors like Fassini corpuscles or Ruffini corpuscles or Golgi tendons are present in the areas which are closer to the joint and in extremities where greater proprioceptive refinement is required. And deep fascia has 70% of sensory innervation and 30% of the autonomic innervation. As opposed, in superficial fascia, we have more of autonomic innervation and less of sensory innervation. So that means superficial fascia has more role in vascularization, lymphatic drainage, thermoregulation, and many factors related to autonomic input. Also, probably is the collection of input from outside to the body that is totally unconscious. So the superficial fascia has different role than deep fascia. This is the electron microscopy picture of the fascia of the thoracolumbar fascia. Here you can see how richly this fascia is being innervated. Certain studies are being carried out to know the type of receptors which are present in different areas. So in masseter, more of free nerve endings are there, whereas in palmar fascia, the capsulated nerve endings and free nerve endings are present along with the free nerve endings as well. Then even in the retinacula, the as we previously discussed that proprioceptive receptors are more around the joints. So here you can make it out. And free nerve endings are present more in masseter fascia, brachial and antebrachial fascia. These muscles do not function in isolations. Fascia links muscle into continuous long chains. Here, Thomas Myers introduced the concept of myofascial meridians. What exactly these are, I'll be explaining later. And this continuation of the muscles, it explains posture, movement patterns, and pain referral. Why it is important to learn these points? Because it gives global view of posture and movement. It explains distant effects. Like if a patient has plantar fasciitis, why should he have back pain? So if we understand the connections, we would be able to treat that patient better. It guides the treatment. It enhances the sports performance and injury prevention. So many of us are dealing with the sports injuries. So it's important to learn all these things. So these are the meridians which I was talking about. So this is superficial backline. Superficial backline starts from, you can see, the plantar fascia, the Achilles tendon, gastrosoleus, then these are the hamstring, sacrotuberous ligament, erector spinae, and scalp fascia. So it maintains the upright posture and prevents forward collapse. Then there is superficial front line. So path is from the tibialis anterior, quadriceps, rectus abdominis, sternocleidomastoid, control of movement. It is formed by the motor neuron and the muscle fibers that its axon innervates. So single motor unit never works alone. It is always in synergy, not only with other motor units of the same muscle, but also with the different synergistic muscles. So study of fascia has led to questioning of several paradigms of human anatomy and physiology. Why so? Because the concept of myofascial unit has been led down by Sticco in 2002. So entity that includes motor unit involved in specific movement, associated connective tissue, the nerves that gives muscular contraction input and the movement perception, blood vessels and lymphatic vessels supplying the area are involved. So in myofascial unit, we just don't consider nerve and muscle. We consider the connective tissues, we consider the blood vessels, we consider the lymphatic vessels in the whole unit. And this term is being used by National Center of Complementary and Integrative Health to announce a grant for further investigation of the myofascial unit. Muscle fibers are totally embedded in the connective tissue, intramuscular connective tissue, and endomysium, perimysium, epimysium, and deep fascia generate the continuum from microscopic to macroscopic patterns. So everything is considered as the fascia. It is endomysium, perimysium, epimysium, and the deep fascia, the septae, which we see are part of fascia. So endomysium is in direct connection with the sarcolemma. So every force generated by the muscle fiber is transmitted to endomysium. So all these concepts are important to learn. So perimysium, it divides the muscle belly into the fascicles of different dimensions. It consists of the proteoglycans and collagen fibers. And type 1 collagen provides a notable resistance to traction. So it is this part of intramuscular connective tissue that has fundamental role in transmission of the force generated by muscle towards the bone. So I'll be consider telling this clinical importance later. So with aging, there has been huge increase in percentage of the collagen. It leads to stiffening of the muscles. And the experiment has clearly supported that muscle fibers and intramuscular connective tissue form a unit, and alteration of one element will affect the other one. So we cannot speak about the muscular aging or the muscle stiffness without taking into consideration the surrounding connective tissue. Now epimysium, it merges seamlessly with the perimysium. It is thicker and formed by the collagen fibers of the larger diameter, and it covers muscle bellies, forming lamina that clearly defines the volume of each muscle. So it merges into the paratendon of the tendons and creates connectivity between the muscle and tendon. So it is very, very important in force transmission. So there are different connections between the muscles. It could be direct connection, it could be indirect connection, and there could be compartmental boundaries. Motor unit I already talked about. So we consider motor unit as nerve and muscle, but intramuscular connective tissue we never talk about. But there are sensory receptors in the muscles like muscle spindles and Golgi tendons and free nerve endings. But recently, many papers have highlighted that there are strong connections between the intramuscular connective tissue and the fascia and the muscle spindles. So what traditional concept we know is muscle spindles are embedded in the muscle and they don't have any connection with the connective tissue. But recent studies have told that the capsules of this muscle spindle are continuous with the connective tissue of the muscles. So uh, the Fan and co-authors have said that older adult mice have thicker muscle spindle capsules with accumulation of collagen type 1 and decrease in hyaluronic acid. So this will lead to failure of motor unit recruitment, and reduced motor unit activity will lead to lower contractile strength of the muscle. It will compromise the regulation of the muscle tone. So with age, rather than decrease in muscle cells, there is reduction in activity of the muscle spindle because of accumulation of the collagen type 1 in the connective tissue. So James et al. Have analyzed the muscle spindles in multifeeders of the healthy sheep and in sheep with intervertebral disc degeneration. So they have found that there was no difference in number and location of muscle spindles after intervertebral disc degeneration, but there was thickening of the connective tissue surrounding the muscle spindle due to increase in expression of the collagen fibers. Now facial pain, it can be more intense than the muscle pain. Muscle pain is mostly dull pounding type of pain, but whereas The facial pain is burning, cutting, and stinging sensation sort of pain. So hypertonic saline solution can cause more intense and long-lasting pain when injected in fascia rather than in muscle. So this facial pain can happen because of the wrong postures, sport injuries, repetitive motions, leading to thickness of the tissues and limiting the glide between the facial layers. And there could be new lines of force generation uh, the fascia between the fascia due to trauma, overuse, or surgery. So if there is increase in density of the hyaluron or increase in its viscosity, it will cause reduction in the gliding of the fascia, and it will activate the nerve receptors which are present in the fascia. So this myofascial unit, which I already explained, it consists of everything. It is the muscle fibers, the nerves, the vessels, the fascia, and the connective tissue. Now, these fascia disorders, they present in different forms. Like if the free nerve endings are irritated, it will lead to pain perceptions. If there is decreased gliding, it will cause muscle stiffness. If there is spindle alteration, it will lead to the weakness. If the blood vessels and nerves are being compressed, that will lead to dysfunction. And lack of free nerve ending stimulation will cause altered proprioception. So facial disorders can present itself in many different forms apart from pain. The MRI studies in the athlete have uh, demonstrated that those who have had the knee injuries, they had more of myofascial junction involvement at the adductor magnus rather than injury at the tendon or the muscles. So take home message is fascia is the richest sensory organ in our body. It has more nerves than eye, more nerves than tongue, and it is 6 to 10 times. It has 6 to 10 times more nerve endings than muscles. And even muscle spindles could be seen as facial sensors, and there could be non-innervated myofibroblasts in the fascia. So, thank you.
हो हो थोडासा तरी
I'm
येते
open
पण
for the questions.
एवढं याला काही नसतं.
Thank you, Dr. Priya, for this insightful talk on fascia is the pain generator. So this is more or less a very neglected thing in clinical practice that I have seen personally. And most of the times they are just at the end of the day they are told that they are having pain in their brains, and there is nothing wrong with them. So, but definitely this thing has to be explored more often than what we are doing at present. So, do you have any questions? If we are participants have any questions, we are open to questions now. One can unmute and ask directly to a speaker also if they want. So I have one question for Dr. Priya. So uh, how generally do we differentiate that the so it can be a primary fascia problem, or it can be secondary to some other thing. Like if you are having some facet abnormality in the spine and then the patient is developing these myofascial syndromes. So these are secondary to the primary pathologies. So generally, what is your protocol whenever a patient of suppose thoracolumbar fascia tightness or that kind of patient is coming to you with some scoliosis and all those things? So do you start your treatment with the myofascial components, or do you target these joints and everything, or what is your protocol? How do you go about it?
See, what I would say is, yeah, definitely you mentioned scoliosis. So that abnormality is obvious that pain originator could be from the spine. But many of the time we cannot differentiate which is the primary pathology. It could be, I mean, it's like egg first or hen first sort of situation. Like if your multifidus is tight, it could put more pressure on your facet joints, leading to facetal pain, or it could be facet irritation, which can lead to multifidus tightness and giving rise to pain. So in my practice, how I differentiate between doing the intervention is, if my patient comes with say pain of around 7 to 8 on 10, then I go for the spine intervention or neural intervention or joint intervention first, and then follow it up with the muscular intervention. If my patient has milder sort of pain, but which is quite nagging, has been there for quite long time, then I start with direct muscular interventions.
Okay. Okay.
So, Dr. Priya, for muscular intervention, do you use dextrose or you do only needling?
I do needling, I do Botox. Dextrose, frankly, I have not much experience in dextrose. I have done couple of cases, but like I'm not in position to tell the results also, because no follow up with those patients till now.
And in the fascia, what do you think is the best thing to for the facial pain? Because these acupuncture specialists, I think they do lot of myofascial, they do lot of facial release. Like I have in my institution, there is a radiologist who gave up radiology and who is doing pure acupuncture, and she believes that science is wonderful. Any pain you can handle. So they do lot of release with the needles actually, acupuncture needles she uses actually. And she says all pains go away. She has a lot of belief. All cancer patients, she's seen wonderful results.
Yes. So acupuncture, personally, I believe it's muscle as well as fascia both. We cannot treat fascia alone. At least in my practice, I have not practiced only facial release sort of thing, but it has to be both muscular as well as facial.
So what I believe is there is no single. So no one should actually say and practice like that. You have only one modality which can treat everything. So that is a wrong way of telling, because what I personally say, even people who are promoting one kind of treatment modality, they use multimodalities, and generally they present it in that way ki they are using this modality, but that is a way of telling that this modality works. So dry needling or acupuncture, uh, I don't know, acupuncture mainly works on the acupuncture points, but dry needling basically targets what are your trigger points, where is the tightness, where is the muscle tightness, fascia tightness, all those things. So along with that other, so not all cases can be treated with only dry needling. So you have to do use other, if you are having some nerve irritation entrapment, you can do dextrose hydrodissections. I have done a few cases of posterior intraosseous nerve entrapments. Then we have done carpal tunnel, so we frequently do. Then interscapular pain, patient dorsal scapular nerve entrapments. We have burning pain in the interscapular area. So all those kind of cases where there is this neurovascular bundle entrapment because of facial tightness. So there these dextrose hydrodissections help.
Also, what I feel that Priya and Sanjog, that it's not only intervention or the acupuncture or the dry needling. I feel the stretching part, which the physiotherapists do, that also plays a lot of role in releasing those tension and the muscle tightness.
Yes.
Because definitely that's the complete, as you mentioned, the front line, back line. So it must be working on that also.
So many of the time, what happens, ma'am, is physiotherapists are very mechanical in treating our patients. Like recently, I have had a patient who has a golfer's elbow. My diagnosis was golfer's elbow. The patient has been going to the physiotherapist. She has been giving her the stretches of the flexors, extensors, everything. She started with the strengthening, but she didn't work on the neck. So, but the once she started with the strengthening, patient had more and more of pain. So I asked her to treat the neck,
Yes,
and she improved. So these are the small
yes,
things. She did examine the neck also. So basically, these things are being taught in physio, taught to the physio people, but they also are not treating the patient holistically. So
absolutely. So it has to be multidisciplinary, as we always mention. And
multidisciplinary, and we have to be their guide rather than leaving the patient on
yes,
their own. They don't like it that whatever
absolutely.
we write, But if we are thorough enough in our knowledge, we can make sense to them.
And even those post-surgical patients, many of these patients have these entrapments in between that thickened fascia. So there also, these patients also, they are many a times neglected, and for months together they suffer from pain. So these kind of treatment modalities related to fascia can help these patients also.
Absolutely.
So, Dr. Priya, sometimes we get these patients, with severe burning pain in the back. They do have intervertebral problems, but I don't know, they never complain of radicular pain. They always tell there is burning pain in the back. And you feel somewhere there is some thoracolumbar fascia which is involved, probably the posterior thoracolumbar fascia irritation. So, have
Yes.
you tried any of your techniques in such cases, and have you had good results?
I always do dry needling in those cases. Always, always.
And dry needling you do only in the region of fascia along with the muscles, and
No,
you do
no.
Botox along with it.
In the case which you said, I do dry needling of the erector spinae, quadratus lumborum, and psoas, and the gluteal muscles.
Okay.
Bilateral.
Okay.
Bilateral.
Bilateral.
It has to be balanced both the sides. It can never be one side. Even though
And how
patient has
many
pain on one side.
how many sittings after how many sittings the patient starts feeling clinically better? Means we have to counsel them. You may need
Yes.
repeated sittings. So
How
how many you usually advise?
See, I usually tell them that you would require 8 to 10 sittings and expect the result only after third session. So if you get result after first session, it is bonus for you. But after third session, if you don't have any relief, then we may have to consider another modality. This is how I counsel my patients.
What would be the other modality would you like to offer? Means if at all this is not helping, what
Trigger.
other modality you offer them?
So then, if I have
Nerve block.
facet as a pain generator in my mind,
Okay.
then I go for median branch block in those cases.
Okay.
Yeah. So whatever
Okay.
primary pain generators which we can
Okay.
think of,
And
them
these sessions you do once a week or twice a week usually?
twice a week. Initially twice a week till the pain settles by 50 to 60%, and then we do it once a week, and then
Once a week.
yes. Initially twice a week and then once a week.
Okay. Thanks. Thanks.
So there is one question from Dr. Titiksha Goyal. Some patients present with stiffness majorly. Is dry needling a good option for them? Is it the fascia which might be involved?
Yes, definitely it could. See, muscle and fascia, we cannot separate those entities. Even though we are considering fascia now, we have already seen that this fascia have connections with the sarcolemma eventually. So, stiffness could be secondary to fascial involvement, and dry needling is, yes, it is very good option for the stiffness. I think that answers
Actually,
the.
you can, Dr. Titiksha, you can ask the question directly, because stiffness can be because of anything. It can be because of even joints. So, movement, stiffness, everything. So, what specifically you want to ask, you can ask directly.
Actually, I saw a patient who had upper back stiffness, neck and upper back stiffness, and the pain was not bothersome. So the pain, the NRS was around 1 or 2. That's it. But he was mainly concerned with the stiffness, which had no diurnal variation, and it persisted throughout the day. So I was a bit confused about what could it be.
It can be the wrong posture leading to the facial tightness. So initially, you have to ask the patient to for the posture correction and do gentle stretches. If it does not settle, then we can consider dry needling in those cases.
So
But
that's
mainly
what
those
I.
NRS 1, 2, sitting job, mobile use, and laptop use are the basic causes. I mean, the wrong posture.
Right now, I've advised for the stretching and the strengthening exercise. That's it. Thank you.
There is one more question. How from Dr. Suhemi Syed. How do you treat fascia? Do you start with hand manipulation first or straight away do hydro manipulation?
None of this.
None of these.
Yes. So my physio does manipulation, manual therapy. And hydro manipulation only during trigger. If I consider trigger point injection, then between the facial layers, I do put some steroid and local anesthetic. But my main is ultrasound guided. My main modality remains ultrasound guided dry needling.
Okay, what are the different modalities according to you which help in treatment of fascia? Like we have ultrasound and IFTs for fascia specifically. Do you have any modalities? So these newer things like matrix therapy, and they work on muscle only, or they work on the whole unit?
Matrix works on the whole unit, I believe. I'm not very sure, but they talk a lot about regenerative this thing regarding matrix.
Yes. Okay.
And they, in the market, there are a lot of machines which are available for the facial release. Maybe not in India yet,
Hmm.
but when I was going through the literature and YouTube, I found many machines which are quite expensive, maybe 20-30 lakhs or so, and they claim that the results are quite amazing.
Okay.
Maybe once we are also in learning phase. Once we try
Yes.
exploring the things, we would be in better position to tell what other modalities than whatever we are already using, the other people are using. Right now, the facial manipulation is being done hardly by any some physiotherapist, manual therapists, the massage therapists. Mainstream mainstream medicine has not taken up fascia as their interest.
Hmm.
So maybe we are the ones who should consider fascia in the research and consider it in our treatment.
Yes, definitely. So that's why we have taken this theme.
Yes.
And let's see, in few further webinars, we will try to explore further. We'll go deep into this topic, and we'll see
Yes.
how we can use newer things. Like everybody's talking about regenerative. So why not regenerative in treatment of fascia? So let's see if we can come up with some things, and till our conference, uh, we will get some good hard hitting topics that we will discuss in a conference. So I hope this webinar and this topic was informative to you. And likewise, we will be coming up with similar topics related to fascia in the coming webinars. I once again thank Dr. Priya Rathi for presenting such a starting this webinar series and presenting this lecture, and gave us a deep insight into the basic anatomy of fascia. That is the basic thing that we don't know. And thank you very much once again.
Thank you for the
That was really
opportunity.
interesting, Priya.
Thank you,
Yes.
ma'am.
Anybody wants to have a last comment? They
I am
can.
sure that it lies much more deeper than that what you have explained. I mean, that's a anatomy that we know, but definitely there is many much more thing into it.
Yes. So if we don't have any questions, then we will end. Okay, so there is one last question we'll take up from Dr. Karthik. For trigger points, which one you prefer, dry needling or any local injection with anesthetic? So dry needling or wet needling, basically, he's asking.
Yeah. So if I feel there are multiple triggers, I would definitely go for dry needling. I wouldn't want the patient to go for wet needling, use more dose of steroid or more anesthetic, because I won't be able to inject everywhere. So, but yes, if I feel that okay, there is lots and lots of irritability, I would start with wet needling, but I would end up doing dry needling in those cases.
Yes.
That's so it varies from patient to patient. If the area of pain is more, I would prefer dry needling. If the area of pain, if there is single point tenderness or single point pain, then definitely wet needling can be the better option.
I'll just check if any other questions are there. Okay, so no other questions are there. So I will ask Dr. Pradnya ma'am, who is the president of Society for Study of Pain, to say a few words.
Thank you so much, Priya. It was indeed a wonderful presentation and a great insight on the huge organ that is the fascia, which is so well innervated. And it is also, I mean, pain is basically due to inflammation, and fascia is one of the components. where you really have to look into when there is inflammation because of pain. So thank you so much for this real in-depth. I mean, I learned a lot from you today. So this is the very new beginning of our series, and I welcome all of you to the conference which is going to be conducted by the SSPP in April. Uh, Thank you very much.
Thank you, ma'am. Thank you, ma'am. Varshali, ma'am.
No, it's
Varsha,
a
ma'am.
wonderful insight that absolutely.
वर्षा मॅडम आहेत का?
I think she left or maybe
Okay.
busy somewhere.
Okay. So this we will end our today's webinar on this note, and we will shortly give you the topic for our next webinar. We'll try to make it more and more interesting, and we will try to get some more and more experienced people who are done good work related to the fascia. So I thank you all for coming today for this webinar. I will just request our EC members to please continue because we will be doing our EC meet on the same platform, and others can have a good night. Thank you.
Thank you, Sanjog. Thank you, SSPP.
Thank you, Priya. Yeah.